Hello students, we will have a case study today. Just see what are the differential diagnosis for this. Look at this, there is a swelling here, some different texture you can see, some nodularity you can see, very well localized swelling. Probably skin is not free, skin is adherent here. But look at that, we can presume that it is mobile, freely mobile from the skin. Skin is adherent, some yellowish nodularity is there. So what it could be, this yellowish nodularity suggests probability is calcified. So it could be calcified cyst, calcified sebaceous cyst can happen, calcified bursa. So all these possibilities are common, probably near the joint. So most probably calcified bursa, probably the diagnosis. So all these three entities you have to keep in mind as a differential diagnosis. And skin adnexal tumor, less likely, but you have to keep in mind as it. Mainly first thing you have to think of calcified bursa, calcified sebaceous cyst, or calcified any cyst as such. Second possibility may be uncommon, but you have to think anything can be skin adnexal tumor when it is arising from the skin. You know that sweat gland, sebaceous gland, hair follicles are the three skin adnexa. The tumor can arise from any of these three entities. So they are called as skin adnexal tumor. And so how it is managed? Examine clinically. Temperature, tenderness, border, surface, nodularity there, skin is free or not, mobility in two directions, always mobility should be checked in two directions, and consistency, once it's surface, consistency, after surface consistency should come, and evaluate afterward, after clinical examination, and regional lymph node should be examined. Suppose it is malignancy, axillary lymph node, if it is in the elbow, axillary lymph node, in the lower limb, groin lymph node, in the head and neck lymph nodes, and evaluate imaging, maybe ultrasound, maybe X-ray, or maybe MRI, maybe better. FNAC should be, and treatment, excision under local, or if you think suspect it is malignancy, then done the GA. If you find difficult to do a reconstruction or suture it, probably will be able to. You can put a elliptical incision and remove it, and send for histopathology. And you can just see how it is done. See that local anesthesia is given here, same swelling, and elliptical incision is passed. Like swelling is like that, elliptical incision is passed. I have put a stay suture here. See that artery forceps is here. Artery forceps is here. I have put a stay suture here. See that is the stay suture. Then stay suture comes along with the swelling. This is the underneath swelling. It's a surface. See that calcified nodules. And this is the defect. And it is sutured with the interpreted mattress suture. So there is how exactly you will do the steps of the excision. So local, if done under local, you could able to approximate. So that is how exactly steps of excision of a cyst actually. When it's well localized, you can do it. When it is mobile, you can do that. If it is extended to the deeper pain, that is difficult. So you can always, swelling examination, you can go through my SRB's clinical method in surgery, SRB's manual of surgery, detailed swelling, everything about cyst, bursas, other things you can detail. Adventitious bursa, you can detail, learn properly. My operative surgery book shows how to do surgery principles. And tissue approximation shows the suturing technique with the video. And my Diginor lectures use all detail about everything, about all surgical topics for undergraduate and postgraduates. We as for CBME syllabus with the specialities, with the operative surgery, X-ray, instrument and specimen. I hope this cyst excision and case study, students, you have understood very well. Thank you very much.